So the goals for today are going to be to present the results from the American Society of Breast Surgeons expert panel on breast cancer-related lymphedema and to update our LYMPHA experience, both at Columbia and I recently moved to Montefiore. So I did also want to give a shout out to Dr. Picardo and to, this is in your handout, and the timing couldn't be more perfect because these are the recommendations of an expert panel from the European Society of Lymphedema, and really they're very much in line. I think the two groups, and I think more and more we have to get as many organizations as possible to really spread the word that this is an important problem and that it needs attention from many people. So I have no disclosures, and this is the crux of it, I think. I think that in the general, certainly in the surgical community, there is still this, idea that what lymphedema problem? My patients don't get lymphedema. When I speak at different groups, a lot of the therapists will come up to me and say, well, that's my problem, is that, our surgeons don't think that lymphedema is really an issue. And I really, if I could use this a little bit as a soapbox, really my pitch is that it's disappointing that there are only 3 or 4 breast surgeons here at this meeting. My hope for the future is that there'll be many. Because when you operate on the axilla for breast cancer, we think about no bleeding, no infection, no seromas, but we also need to think about what is our plan surgically to reduce an iatrogenic injury, which is lymphedema. I mean, we do this as breast surgeons. We feel guilty when this happens. You should. So what can be done to change that? And there are lots of things, as it turns out. So this was our panel. So this was sort of my idea, but all the work in typical fashion was done by Sarah McLaughlin, who's a surgical oncologist. But we had a very, very good group. Francisco was part of it. We had Suzanne Klimberg, who has done a lot of work with axillary reverse mapping. And then we had some of our colleagues from the UK, Fiona McNeil, who's the president of their Society of Breast Surgeons, and Paul Thruchavalin, who's a young surgeon who's been very involved in lymphedema. As a matter of fact, he has a Churchill Fellowship, and he has traveled the globe to go to all the lymphedema centers to really see what different people are doing around the world. So really a fantastic group. Michael, who's here, is a lymphedema therapist. Mark was part of this, talking about lymph node transfer. Radiation oncologist Stanley was part of it. So we really had, I think, a very, very well-represented group. And the topics to try to resolve were really huge, and we couldn't cover them all, and these have all been touched on today. Patient concerns, risk, defining the diagnosis, existing guidelines, surgical techniques, exercise. So and this is not a consensus statement. We couldn't really, that would take probably a year or two to do, and really there's not enough literature to do that in a meaningful way. So it really is an expert panel, but we tried to drill down to what we thought were the most significant areas where we could make some statements. And this was published. Again, Sarah did really all the work. I'm the senior author on it, and the whole panel contributed to this. And the process was people really explored the different areas, wrote parts of the paper. We came together as a panel, discussed it. It was synthesized. It was presented at our annual meeting. There was then a period of review and feedback from our membership about the recommendations, and then it led to 10 recommendations, which I'll share with you briefly. So I think number one is that surgeons should admit and accept that lymphedema risks exist. This sounds like, again, a small thing, but it's probably the most important part of our recommendations. They need to educate themselves and their patients. And then one thing that I thought was very good was that education should continue into survivorship. And now we all have to do survivorship care plans through the National Accreditation Program for Breast Centers, NAPBC. So at those those follow-up visits, where often are with the medical oncologist and maybe not with the surgeon, there needs to be some information about, are there lymphedema symptoms? Is there something that needs to be looked at? So I think that's very, very helpful. And this is, very basic, a surveillance plan, as many people have talked about today, because that can lead to early diagnosis and decrease disease burden. And then arm measurements, of course, which is a hot topic, the best way to do it. Of course, it has to be bilateral. And then all the measurements that we know have advantages and disadvantages that need to be considered. And it's clearly a combination of both objective and subjective, and patient-reported outcomes and symptoms are extremely important. So in terms of, what's the best method? So, self-reported symptoms, of course, important. It's cheap, but it's very subjective. Perimetry, very, very good, quick. Gives a lot of information. It's expensive, has sort of a large footprint. So volume displacement, water displacement, which is a very good technique, but it's messy in terms of the water. It's not hygienic. Arm measurements, which with circumferential tape, certainly are good, but problems are that they require training. They're time consuming, and they often don't get done, but it certainly, as a basic, is very good. And then, bioimpedance spectroscopy, which I think is a fantastic modality. Many centers have used it. I think their new platform, the SOZO, they're here at this meeting, and I don't have any financial relationship with them, but I do think that will be a game changer because it's a very easy way. Patients come, they get weighed, they go on this device, you get a volume measurement, done. Because I think what happens with the standard device is that there are electrodes, there's some expense to it, but if it's a high volume center, I think you're going to be using that device quite a bit. And I do want to, so one disclosure would be that our lymphedema panel was supported through industry support by ImpediMed, which we greatly appreciated because otherwise it wouldn't have happened. So I think that there are different ways and different pros and cons to the different modalities. So this, I think, is very important. Clinicians should practice personalized medicine to minimize axillary surgery, should question the routine use of post-mastectomy or regional nodal radiation, and really, it's changing. It's more about biology now than ever. So using genomic tests to guide the use of chemotherapy, because all of these modalities, surgery, radiation, and chemotherapy, all are additive in terms of increasing lymphedema risk. So, for example, we're doing many less axillary node dissections these days. It's good news for patients because so many patients get neoadjuvant preoperative chemotherapy. So if patients are node positive, they get treated up front with chemotherapy. Lo and behold, the data suggests we can do sentinel node biopsies post neoadjuvant chemotherapy. They don't need to be dissected. Or we're really being much more minimalist in terms of our approach to the axilla. And I think a lot of, even for patients with positive sentinel nodes, they don't all need to get dissected if they have breast conservation because they're going to get radiated. So I think we need to continue to educate breast surgeons about we don't have to overdo it. We're not really curing patients by taking out that one last micrometastasis in one node. That's really not the game changer for patients. It's really the systemic therapy that's much more important. So we have to be mindful of all this. And of course, as has been discussed here, maintaining a healthy weight and BMI is extremely important to reduce lymphedema risk. And then, as was elegantly shown by Dr. Roxon last night, the mechanistic theory is certainly too simple. It's not just the train off the track and a blockage. I mean, it's certainly a very, very important part, but there are lots of novel areas looking at gene expression, inflammation, and targeted anti-inflammatory therapies in the future hopefully are going to really help this problem become less of an issue. And then the whole idea about historical risk-reducing behaviors, which has been discussed, there's been a lot of back and forth about it. I certainly don't think it's bad to be careful and for patients if they're nervous to avoid, but I think there's really no evidence for most of these things. If a patient feels more comfortable wearing a sleeve when they fly on a plane, let them wear a sleeve, but they don't have to do it. They don't have to live their lives in fear that if they accidentally have a blood draw, or blood pressure taken on one arm, that, oh my God, what's going to happen? Because it's just not practical, it's not real. So I think we want to decompress that a little bit because there really there's not very good data on the risk of IV, venipuncture, flying. And then sauna, I think there's one or two studies that really suggest that it does increase the risk, and I think caution there is definitely better. But personalized discussion about this, I think, is the way to go rather than extreme paranoia. Exercise is good, so I think that's something which has been back and forth a little bit about not lifting, not doing exercise, but I think we want to encourage patients to actually do exercise, supervised exercise, either with a trainer or a lymphedema professional to learn how to do it safely. And all the studies suggest that actually lymphedema will reduce the potential consequences or risk of lymphedema. And then the emerging strategies, which we were discussing this morning, that they're very promising. Axillary reverse mapping, which I'll speak a little bit more about, I think is an extremely important technique. My hope would be in future meetings like this that there would be more substantial discussion of the technique, and I think it is something that should be incorporated into the armamentarium of breast surgical oncologists, because I think that not everybody's going to have the ability and the team to do lympha in patients who need to get dissected, and in order to minimize the morbidity of axillary dissection, axillary reverse mapping, not just for sentinel nodes, but for patients who have limited axillary disease, is a very, very effective modality, which a lot of studies have now shown really reduce the risk of lymphedema. And of course, the most important thing, and hopefully some of the outcome from this meeting will lead to it, is that we really need prospective trials of LYMPHA and of ARM from multi-center before these will really get the traction they need in terms of being generally accepted by the medical community. And of course, for affected patients, comprehensive decongestive therapy is the cornerstone of therapy, as has been discussed, early referral and individualized treatment planning for affected patients who have lymphedema is extraordinarily important. And last, that acknowledging the developing treatments for secondary lymphedema, including lymphovascular anastomosis, lymph node transfer, are very, very important. I think there's more and more data that's suggesting that these are very, very effective. Our recommendation is not quite as strong as the European group, but I think they're more, definitely ahead of the curve in terms of lymphedema understanding and treatment. But again, as has been stressed earlier in this meeting, these patients have to be evaluated by a multidisciplinary team. They have to be carefully vetted. They have to have appropriate imaging. Just as Drew showed here, the model at BI Deaconess is fantastic, where it's basically like a team meeting, tumor board type approach, making decisions about what's appropriate for the patient. Unfortunately, in practice, there are individual physicians who do lymphedema surgery, but they're doing it in isolation, not as part of a team. And as some of you may have seen, the patients don't always have the appropriate operation and the outcome that would be hoped for. And then liposuction, we thought, as has been demonstrated here by our colleague from Sweden, depth with compression is very, very helpful for refractory disease. We did not really, so our recommendations didn't cover the debulking procedure, which I think the ESL does cover, and I think we really didn't have someone on the panel that was an oversight who was an expert in that area, but I think as well has been shown here that that's an important modality. So this is it, right? This is Henrik, of course, have to give a little Ranger plug. But it is about prevention, and really, we would love, secondary lymphedema, the pool of patients who are out there, it's a massive volume of patients, but we need to be really focusing. Number one is on prevention. It has to be. So we really have to begin to look at how to do that. And I think that LYMPHA is really an amazing approach for that. So the evolution of LYMPHA, so of course Francisco and his group in Genoa have really done the key work. But in classic fashion, when one of our residents was looking at publishing our series, he unearthed Vladimir Pronin, who in 1989 actually employed LVA like 1 day post-op after radical mastectomy. Got it translated from the Russian, and so a lot of things not always new. They're always standing on the shoulders of prior giants, but that was buried. Nothing ever happened with that. And then LYMPHA came along, and the Genoa group really has done amazing. They've really been the leaders in this. And then they reported their results in 2011. Showing 4% for control versus 30%. We opened our trial at Columbia in 2013. I got the opportunity to visit with Francisco Serra, his assistant, Professor Campisi, some of the trainees. They're training a really amazing generation of lymphatic surgeons to come. In 2014, there were no lymphedema in 71 of 74 patients that they reported, so really it was looking great. So in terms of my personal journey here, so really I first heard about LYMPHA in 2011 at the American College of Surgeons meeting when there was a brief presentation. And it really was one of those light bulb moments, that like, wow, this is incredible. You can really do that? Makes sense. We always tie off the lymphatics in the vein. Why not put them back together? Shortly thereafter, I visited Francisco and Professor Campisi in Genoa. It happened to be, I remember that visit so well because it was election day. And Obama was reelected. So it was a little different environment in the world and in the United States that day, but it also was the 500th anniversary of the medical school in Genoa, which was founded in 1512. So it was a pretty interesting day. So we did our first LYMPHA procedure in January, and then Professor Campisi visited us at Columbia, and we have had a wonderful back and forth relationship. I presented our Columbia experience at the European Society of Lymphology in Genoa in 2014. We published our paper in 2015. Professor Picardo visited us at Columbia in April and actually came to the OR. It was fantastic. We showed a video of our LYMPHA technique at our American Society of Breast Surgery meeting in April of 2016. So this is my first LYMPHA patient, and sometimes things really work out. So this was she's now almost 5 years out. So she's 74. So she's a nun, and this was our first patient. So it's always a little challenging with the first patient about, have you done this before, doctor? No. I did go to Italy and met Professor Picardo and Campisi, and watched them do it. And, I think it'll be okay. She was very worried about lymphedema. As you can see, she's heavy. She works with a walker. She was really worried that if she had any morbidity from her arm, from her node dissection, that she might not really be able to get around. And her being a nun was helpful because she had faith. And so we continue to be. So I call her sis, and she calls me bro, and it's all good at this point. So this was our paper that we published in 2015 in the Annals of Surgical Oncology. And as you can see, the authorship, these are our plastic surgery colleagues, our nuclear medicine colleagues, other surgical oncologists. So it really is a team to do this work and to really analyze it. And of course, Dr. Banzel, who's now in Providence, really did all the work. She was our fellow, and I stole first authorship from her. So we updated our LYMPHA experience in San Antonio last December, which I'll share with you. And then, I've had surgeons from around the U.S. come to Columbia to really observe and see how we're doing LYMPHA. So the interest has definitely grown. There's been a lot more enthusiasm, I think. And then in January, I moved to Montefiore Einstein. We actually did our first patient there in July, and now we're presenting our updated results here. So the selection criteria, as you can see, as Francisco showed you in terms of the Genoa criteria. So our criteria were different. We really were selecting patients who we thought were high risk for lymphedema. It turns out their average BMI in our series was 28. 70% of them received post-mastectomy radiotherapy, 50% of them received neoadjuvant chemotherapy, and they were a high-risk group, the average of 4 positive nodes in their axillary dissection. So we were using, I think, more clinical criteria to just, in our judgment, if the patient seemed like they'd be high risk for lymphedema, we wanted to offer them LYMPHA. And we monitored them very closely, so we got lots of data points in terms of lymphscintigram, pre-op 3 months and at 18 months, clinical assessment. We used LDEX throughout, along with arm measurements. And this is just showing, so our technique of LYMPHA, we're averaging about 1.5 lymphatics, anastomosed. But for those of you who are, so there, there's the arm is here, there's the blue lymphatic. You can see it's nicely dunked into a branch of the axillary vein, competent valve. And we still do, when we do axillary dissection, we do very classical, still skeletonizing the axillary vein, which I know is not always done anymore. Added about 45 minutes and no complications related to the procedure. And, Francesco and I were talking earlier, well, why not do LYMPHA if you feel like you can do it? I mean, the downside is it takes time. You need to use some blue dye. It's not an expensive thing. We normally tie off that lymphatic. We normally tie off that venous branch. If the anastomosis doesn't work, it's not like the flap is going down. It's basically, there's no harm done. So there's really no reason not to be aggressive considering this technique. So now our updated results. So 53 patients, 43 who've had completed LYMPHA procedures. The mean age is 54. Most of it was done by 3 surgeons, a couple of my colleagues at Columbia. Most of the cases were mine, about 35 of them. And we had, as Francisco mentioned, there was a real learning curve. There were 10 unsuccessful during the first 25 cases because of vein being inadequate or we couldn't detect the lymphatic. The patient selection, as you see, the BMIs were high. And then we really, again, we're estimating patients whose lymphedema risk would be over 20%. Most of the patients had mastectomies, 4 positive nodes. The average axillary dissection was about 17 nodes. And now at 30 months of follow-up, we have a 7% breast cancer related lymphedema rate versus 31%. We looked at our historical lymphedema rates in patients from the prior 5 years who were matched, and it was about 30%. And interestingly, about 50%, or 5 of the 10 patients in whom we attempted LYMPHA, but it could not be performed for technical reasons, have developed lymphedema. So we think this is significant data that encourages us to continue. So my current approach to lymphedema prevention, I think the most important thing is less axillary surgery and really be mindful about axillary surgery. Sentinel node certainly has less lymphedema risk, but not none. And as I mentioned earlier, pre-op chemotherapy for node-positive patients. We have the discussion always with patients, local therapy, systemic therapy. You're going to need both if they have significant disease. Which goes first? If it's clear that they're going to need both, and the systemic therapy recommendations are not going to be changed by the results from surgery. Why not give them the systemic therapy first? You downstage their tumor, you see if the drugs are working, and you downstage the axilla so you can do less, and they have less morbidity from dissection. So we've stopped doing sentinel node biopsies for many patients unless it really will affect their systemic therapy, because the genomics and the biology of the tumor more than ever are really driving the systemic therapy decision. Why do we do the axillary dissection? Why are we doing a sentinel node biopsy? It's a staging procedure. There aren't that many patients who we really cure of their disease by doing an axillary dissection. We do LYMPHA. If patients get neoadjuvant chemotherapy, don't have a good response, have bulky disease, we're worried about axillary recurrence, those patients still need to be fully dissected, and LYMPHA is great for them. The patient should be monitored with sequentially pre and post-op, and education and early physical therapy are the keys. So thanks so much for your attention.